broadcast, James? Are we not live to the world?
Yeah, it's just getting.
Thank you. Just to start off with that, I think it's always nice to sort of update us a little bit on how life is going. We can see that there's been a sibling study done on paracetamol, showing that there's no link between paracetamol and autism, as was previously put forward. And the sibling study was the most important aspect of actually identifying that there's no connection between the two. But I remind people of the increasing threat of measles and falling vaccination rates around the country, some as low as in the 60s for second MMR, and we mustn't take our eye off the important things that are out there. I spoke at the East Midlands Combined Counties Authority yesterday and encouraged them to see Derbyshire and Nottinghamshire in terms of fluoridation of drinking water. Brought it to the attention of the Mayor and said this is an absolute essential for any forward planning with regards to the dental care of the children of the Strategic Authority. I'm just going to finish by saying there's a couple of things before we go on to the main agenda. It looks like the assisted dying bill is going to fall by the wayside due to 1,000 objections and alterations from the House of Lords. So that may have to come back again at some stage. And lastly, the thing that caught my attention was wood fire burners. I don't know how many of you got a wood fire burner in your house. Oh, there he is. It's thought that this is the new cigarettes. This is the new cause of lung disease, heart disease, lung cancer, etc. The 2.5 micron particles being released by wood fire burners is thought to be in 1 in 10 houses in the country. One of the next great challenges that we've got going forward, and it may end up on our work schedule and joint strategic needs assessments as we go forward. And just to finalise before we move to the matters at hand, I have asked the Public Health Department to commission a joint strategic needs assessment on the physical and psychological effects of recurrent traumatic flooding in houses around Nottinghamshire, particularly the effect that causes anxiety, causes depression, causes suicide, it causes relationship problems, it causes exacerbation of diseases, to name but a few. One of the great overlooked challenges that we have in our communities is not about the water. The water comes and the water goes, but the chronic long-term effect or serial recurrent traumatisation of these families has been going on for too long, and I've asked for a joint assessment to be started on that. Now, as if you thought the meeting wasn't long enough, I put that little addendum in. So what we're going to do is we're going to move forward, and I'm going to ask you to look at the minutes of the meetings that was last held, and those minutes of the meeting are basically for noting only, as opposed to giving rise to discussion. So I'll ask you to cast your eyes over those minutes and look at the various pages. You can see that we talk about rough sleepers, the only instance where women die younger than men. So in addition to that, it is integrated neighbourhood services, etc., and the wood work programme. Are we all in favour, those of you who were here and can actually validate that these are clear representation? Yep. Okay, James, we're going to take it in the minutes of the last meeting, have we? Do we, James, have any apologies for absence today?
We have received apologies from Councillor Angie Jackson and Dr. Dylan Bartholomew. Thank you, Chair.
Do we have any declarations of interest, pecuniary or non-pecuniary? If that is the case, declare them now, or if it comes to you later on in the afternoon, you can equally declare them then. I think we can say that's a no, James. So let's have a little look. We're on now. We've got a number of items from 4 all the way through to 3 o'clock. We'll take a little break at 3 o'clock. I promised that there will be tea and coffee and biscuits. But I haven't seen any of them, I have to be honest, so far. So then at 3:15 we're going to have a workshop, and that should hopefully bring us through till 5 o'clock. for those of you who remain. Item number 4. Item number 4 is the Joint Health and Wellbeing Strategy 2025. This is the ambition of healthy and sustainable places. You'll remember we've had 4 ambitions. One is giving every child the best chance in life. We have healthy and sustainable places. We have the opportunity to improve people's health, and we have safe communities. Last time out we did safe communities. This time out we're doing healthy and sustainable places. I'm actually going to pass over to, in a minute, Ellie Story and Carol Ford to introduce the report. But before we start, there's a couple of errors that need to be disregarded in the report. Page 3, line 1, there are 3 opportunities and not 6. So page 3, there are 3 opportunities. So it says at the top of it, article, it says number 14, there are 6 opportunities for the action the board members outlined in the Q3. I remember reading it and I managed to count 6, so, but it says there are only 3. And in paragraph 16 and 17, it says to be disregarded as support has already been provided to the board. With that in mind, we'll go over to Ellie and Carol. Thank you.
Thank you, Chair. Good afternoon, everyone. My name is Ellie Story. I'm Senior Public Health and Communities Manager here at Nottinghamshire County Council, and I lead on the Healthy and Sustainable Places agenda within the public health team. And it's my pleasure to be introducing this report to you all today. But you're going to be hearing not just from me, but from colleagues across the system who are working on this broader Healthy and Sustainable Places agenda. So the purpose of Healthy and Sustainable Places, can I have the next slide, is to make sure that we are creating healthy areas, healthy places where people can live, grow and work. One of the really important things to note within this area of work is that this is not just within the realms of what public health can do, within what even the county council can do, but this is delivery across the whole system. And lots of this work is happening at place in our neighbourhoods directly with our residents, working to improve their building blocks of health, so things like work, employment, the food they eat, having warm homes, etc., will impact their health outcomes much more significantly than, for example, access to healthcare services. And we know where those building blocks are missing, that people's lives are cut short as a result. So it's really important that we keep strengthening those building blocks of health. So in terms of what we're going to do today, I'm just going to run you through a few of the highlights of the last 12 months, but the bulk of the presentation will be colleagues who are joining us, who've been working on our Investing in Communities programme, who are going to tell you a bit more about some of the work that's been going on there. And then we'll wrap up and give you a bit of an update on what we plan to do in the next year. Next slide, please. We'll skip over the building blocks as well, because I've just given you a revision of that, and anyone who's coming this afternoon will also get further revision on that. In terms of key opportunities then, key achievements rather, there's been an awful lot of work going on, and again, this is a real snapshot. There is so much work happening in this space. This is just giving a little bit of an insight into the sorts of things that we've been doing across the system and working with our partners. The key thing in this space is partnerships. We cannot do any of this stuff on our own because the statutory responsibility sits with different organisations, with districts and boroughs, with the county council, with MCA now, within the NHS, within different partners. So it's absolutely essential that we're making sure that we're working together to understand where we can maximise our opportunities to improve the people's building blocks of health. One of the key things I'd also say is lots of this work is happening at district and borough level. We've got fantastic health and wellbeing partnerships, fantastic work going on in our place-based partnerships. For example, in the food work, lots of that work is happening through local food partnerships in those spaces as well. So if you've got any questions about where you might be able to connect into any of those resources locally in any of your areas, we'd be really happy to signpost you to those. I'm going to take most of those achievements as read in the report because it's quite detailed and quite small on the screen. Just to say that there is a huge amount of work in train, and what we're really trying to do is making sure that we're maximising in our policy space where we can to be influencing policy and decision making and strategising so that we've got good health and wellbeing at the fore of all our decisions, particularly thinking about things like planning, and we've got things like health impact assessments that help us as tools to be able to make those decisions. I'm now going to pass it over to Carol, who's going to introduce some colleagues regarding the Investing in Communities, which is kind of a deep dive for today. But I'll be back with you later to do a bit of a wrap-up.
Thanks, Helen. Everybody hear me okay? So hi, I'm Carol from Public Health, and I'm just going to give a really brief introduction to the Investing in Communities programme, and then we'll bring in our colleagues from Mansfield CVS and Citizens Advice who've joined us to bring this to life for us. So it's a public health funded programme. It's been running for 3 years. It's in its last year of delivery. But the purpose of the programme is to strengthen our place-based partners' ability to deliver Ambition 2, with another core aim to increase action on the building blocks of health and to address health inequalities. The programme has a real focus on listening to communities, building on existing programmes and partnerships and existing learning. It's an asset-based community development programme, so in all of the areas that it's working, it's increasing community development worker capacity, it's supporting new grassroots community groups and existing community groups, and then supporting the development of volunteers. And in all areas, it's got a focus on reaching priority communities and priority groups, so that includes groups like old people and those with long-term conditions. We've aimed for it to be a really collaborative approach, so we've had a bit of more of a creative approach to the way that we've commissioned this, really encouraging collaboration with place-based partners, with delivery partners, and what we're finding is really strengthening relationships in that delivery. Now, last year we came to the board and we gave an update, and we had a bit of a spotlight on some of the work in Manton, in Bassett Law, and Coxmore in Ashfield, and we brought partners in, but today we really wanted to spotlight some of a particular model of good practice that's emerging in Bellamy Estate. So I'm going to invite colleagues from Mansfield CVS and from Citizens Advice. I don't know if we can, if there's a way that we can, if you want to take my seat, we might move so that
This really is musical chair.
Yes.
we'll move out. Okay. Yeah, so we'll invite colleagues in to share some reflections on how this is working in Mansfield, just to really bring this to life, think about the impact of the programme, what we're learning about the impact on people, communities and partnerships. So,
I've got to ask Carol, how long have we got?
10 minutes.
All right, we won't talk all day then, we promise.
No one can out-talk Dr. Doddy anyway. So
Is that true? Is that all right, Stella? Yeah?
Please can we get the slide up that looks like this? Lovely. Thank you. Thank you.
And if we could get you all to introduce yourselves and then carry on.
I'm Leslie Watkins from Mansfield CVS.
I'm Sally Bestwick. I'm the Operations Manager for Citizens Advice Central Nottinghamshire. We've been doing the work in Mansfield as well.
So in Mansfield, for our investing in communities areas, the areas that were chosen were Oak Tree Lane Estate and Bellamy Road Estate, who are both priority wards for Mansfield District. And we're deciding today we're going to focus on a piece of work that's happened in Bellamy Road Estate, because it's really much further along, because it's building on prior work, some NHSEI funded work. And I think, as people know, Bellamy Road has been a priority ward for a long time, back to days of neighbourhood renewal. And we've seen a lot of investment come and go, some of it quite short term, some piecemeal stuff. But what we've done in Bellamy is really invested, working alongside the community, and we've got a very strong community in Bellamy, and I don't know what life on that estate would be like if it wasn't for those residents and those volunteers. They are amazing. And we've got, we work out of a building called Trowell Court Community Centre, which is a Mansfield District Council building. And what we decided to do is to take over Trowell Court on a Tuesday, literally Trowell Court takeover day. And I think the model works really well, and it's really efficient, and I mean efficient for cost as well. So Mansfield CVS, through the Investing in Communities Fund, we rent Trowell Court. Nobody else has to bother with that. Nobody else has to bother with signing agreements and renting. We rent it, we have the keys, we go up, we open up, and we've got a co-location point, and Mansfield CVS act as a coordinator. So we're making sense. People aren't just coming in and, because everybody wants to come, and we'll come and seat residents and we'll do this and we'll do that. There's that sort of coordination going on, and I think that's really important. So on any given Tuesday, we have the Children's Centre do outreach there, because there's no Children's Centre on Bellamy anymore. We have Stand Guide, who are offering employment support. We have now Family Action around health, fuel and finances, and most importantly, we had citizens advice, and also my colleague Kirsty, who is funded through Your Health Knots, is the health and wellbeing officer for Bellamy. So there's a lot of things happening, and I think just bringing everything to the people on the estate and people building that trust, and it's been a really, really effective model. And I don't know if you wanted to say a bit about what the outcomes that have been for citizens advice, because Steve is really busy every week.
Yeah, so the role that we play is we put a paid advisor in there. It's really important that it is a paid advisor. We do use volunteers as well in our service, as probably most of you know. But the reason why it's a paid advisor is that person is there every week then. We're not changing that person, and that person gets trusted. You know, people come in and see him who probably haven't been out their houses for weeks, and they'll seek that out because they know they're there week in, week out. And the work that he does, it's quality assured, we're FCA regulated, you know, that is really important, that the quality of advice is right as well. So that's why it's a paid worker. But I think we fit into these building blocks of health together as a group, not just citizens advice on its own. We can do a lot of those: citizens advice, money, resources, housing, you know, freeing up those barriers that people have to going back to work or probably volunteering. We're reducing that stress and anxiety that people are suffering because of all those things that I've mentioned: debt, money, resources. They might have got ill. You know, the cohort for this group is later working life. They're the majority of people that we're seeing. People are getting sicker in later life and they need that support. They may have to change careers, you know, they may have to do some volunteering to get back their confidence back. So all that work is around this one place. And I think that's the importance of this. It's the place. And there was not a lot going on there, was there, to start off with when we first went in. And I know the first time I went in, I went specifically on a morning when there was a coffee morning to meet the residents. And I said, what do you want from us as a service? And they said, well, you don't answer the phone and you don't fill in forms, do you? So that's what they thought of our service, you know. And I said, no, well, we do both of those things and we'll prove it to you. And we have. It's been really successful. You know, there's been thousands and thousands of pounds put back into those people's households by maximising their income, looking at their budgets, making sure they're not paying excessive amounts for gas, electric. We put them on social tariffs. We do the Big Difference scheme. You know, all those things aren't advertised on the telly every evening. People don't know about them. It's our job to make sure that people are in a safe, you know, and they can not only survive but thrive. That's our job as a citizens advice service. But it only works because we're all together in that day on that locality.
And I think we all work as a team, we all trust each other, and I think that's really important when you're working with somebody who's vulnerable. If you need to make an onward referral, then having confidence is really important. And I think, you know, we can look at some of the building blocks. We all know that transport is an issue that's been brought up time and time again. Bellamy Road is distinct from Mansfield. It's not that easy to navigate to and from, particularly if, you know, if you're frail. And there are no healthcare services on Bellamy. There's no GP surgery, there's no pharmacy, there's nothing. So we've also done as far as we can. We do try and bring some health services onto the estate. We would like to escalate that, particularly tap into what may be happening with a new investment on Bellamy Road estate and a new building, because we'd love to bring some health services. John, we'd love to do a flu clinic or, you know, or vaccinations. We stumble because of its locality. We do have some barriers because of the locality of Bellamy being on the edge of Mansfield. The residents sit within at least 3 different primary care networks. So that can sometimes be a barrier to us bringing health services out. If it's a commission service that's delivered across the whole county, then that's not an issue. But sometimes if something belongs, you know, it's like patient safety, whose contract is it, that sort of thing. But taking things to the people in the community has really worked. If anybody ever wants to come up on a Tuesday to Bellamy Road, come and talk to the residents, come and see what's happening. We've had things like diabetes. You know, you sit around the table and you can have a conversation, and Kirsty and I make a joke about being on a diabetes, and every person on that table sits there and tells you they're type 2 diabetic. And that's not a shock to them because that's the norm, and they'll sit and discuss the medication and they discuss their numbers. but we'd want to take some services out there. We're limited, we're very limited for space. Trowel Court is not ideal, David, is it? But, it's not always accessible. We've got very limited private space, confidential space, but we really want to grow that. And this really is truly neighbourhood working. It is a neighbourhood. And I don't know if
there's lots of other barriers, isn't there, like digital exclusion up there, and people haven't got the ability to fill in forms online. So that's one of the things that we do. It's not the best use of our time, but if that's what people need, then we'll help them with that. But
we've got residents that can't. We've got residents that can't read and write. We've got a lot of people who have got hidden disabilities and a lot of learning disabilities. We've got, I think, what's the SEN rate at the school? Is it 60% or something at the school for special educational needs? There's lots of issues, but I can't tell you how fantastic those residents are and those volunteers. And if there's always something happening on Bellamy, but this model has just worked really well. And I think as a workforce, for people out there working on their own, because we forget about workforce sometimes, and they're really important in all this, that when people are working on an outreach, we're a team. It doesn't matter that we all work for different organisations. We are a team at Bellamy. And to see somebody come to Bellamy because they've been referred to Citizens Advice, and they go and have an appointment with Steve, and for Steve to walk out of that room with that person and then go to Angie from Stand Guide, right, is ready to look for work now. It's been with Steve 6 weeks, done whatever he needed to sort out the chaos and the problems. And Steve's holding somebody's hand and going, right, this is Angie, she works for Stand Guide, she can help you look for work now. And then we would say, and did you know that on a Friday there's a food club and you can get this and we can help you with that? It's just, I think it's a brilliant model, but I would say that.
I think this fund is because it was flexible in the beginning, it's enabled us to shape it. It wasn't too rigid in the criteria that you had to meet, really. And I think that's really been refreshing. And that's what we've been able to do, isn't it? Our stats, our database is quite comprehensive because it's a national database, but we can pull stats off there. 78% of the people that are on this project and the other kind of early intervention type of work that we do, 78% have a long-term illness or disability. And the issues that they come with us are between 7 and 11 issues per person. So we have to unpick all that. It takes many weeks. It's not just you have an appointment for an hour and that's it. It's time-intensive work. But it just works because we're all there together, like Leslie says, working as a team.
Thank you. Do you want us to stop now? Because we could talk all day. We could stop there.
Thank you. Thank you.
Sorry.
Yeah, so thanks ever so much, Leslie and Sally, for bringing that to life for us a little bit. Can I get the next slide, please? It might be one after, actually, about evaluation. Briefly, I know it's a bit small to read, but I wanted to take the opportunity to talk a little bit on the evaluation that we're doing as a programme as a whole. So that's one example. The programme works across the county in a number of different areas. Briefly wanted to share some key points from the learning so far. It's really hard to evaluate this type of work. It's complicated, it's community-based, it's partnership-based. So we try really hard to evaluate it in a meaningful way. So yeah, we're keen to build the evidence base, we're keen to share learning. We really want to inform what comes next with the learning from this programme. So thinking about work that's going to come through throughout the communities and through developing neighbourhood working. So we've done a lot of evaluation. It's mixed methods evaluation. We've got a lot of feedback from residents. So there's 89 residents that have been part of these different programmes that have fed into the evaluation. We've got some participatory approaches, feedback from partners. And I just want to share some of the key messages that you probably can't read on those slides. So what we're hearing so far is that the programme is increasing action on building blocks of health, now particularly of social isolation, so increasing connections. That's one of the key things that we're hearing. That's really closely followed by skills and employment, so lots of improvements in skills and employment. The programme is reaching priority groups, it is reaching priority areas, it is amplifying resident voice. So from the outset, we were really keen that it was building on what we were hearing from people. We get a lot of feedback that it is strengthening relationships, and I think Sally and Leslie articulated that really well about this feeling of being a team across different organisations, how supportive that is when you're working in a community. But we're also hearing about how it's supporting an avoidance of crisis. So there's this idea that these wraparound models have got the right support in the right place at the right time, and that kind of opportunistic support that can avoid those kind of crisis interventions from more statutory services. And some feedback that we're getting from partners is that the way that this has just been commissioned a little bit differently, it's been given the freedom to evolve and respond to what we're hearing in communities, that this is just a different level of partnership working that we're seeing. And the shift, I think Sally mentioned, from like surviving to thriving, this shift to thriving. So there is something a little bit different that we're learning about this programme that we really want to build on. So I'll leave it there on the investment communities. The evaluation, we've still got a little bit more to do, so we'll be sharing a bit more, but this key learning for now. Can I get the next slide, please? Thank you. So back to the programme as a whole for Healthy Sustainable Places, just very briefly some of the challenges that we want to highlight across the presentation. It's just, as a programme, it's really wide-ranging, it's really broad. As Ellie was saying, it's delivered by lots of different partnerships, lots of different parts of the system, so it's just kind of hard to report on and manage as a whole, so we can only ever really share a bit of a snapshot about it. Really wanted to highlight short-term nature of funding for some of our community-based approaches, so the approach that we've just discussed, short-term funded, so that's always a challenge, and also our evaluation, I think, is really important, so we can tell a really strong story about that work. There's lots of changes across the system. It relies heavily on partnerships, so that just makes it a little bit more complicated. So I think the mitigations there are for us to be kind of responsive and to just maintain those strong relationships that we're building across the partnerships, strengthen our evaluation approaches. Okay, and I think hand back to Ellie then.
Thanks, Carol. Next slide, please. So to wrap up, to give you a bit of an overview of where we're at across the outcomes, one of the things I would say is these are kind of broader national level indicators, and you'll see overall we're performing pretty well on lots of these areas that look at the wider determinants of health or the building blocks of health. I think one of the key things to understand is that is again purely a snapshot, and the challenges with Nottinghamshire county level indicators is that they mask quite significant inequalities within the whole county. So for example, if you think about ones around employment rate, we know that, for example, we have significantly higher economic inactivity due to ill health, for example, in mid-knots, particularly among women, for example. So it's really important that we delve more into that detail, and that's where our JSNA chapters come in, and they've all been through this board previously, but you'll see those links there, and I really recommend having a read of those if you've got any questions. Next slide, please. Yeah, so in terms of the next year is going to be huge in this programme because we've got some very significant opportunities and challenges coming our way. The increase in powers to EMCA are a really great opportunity. We're working very closely with EMCA colleagues, particularly around employment and health, particularly around the local transport plan, etc. There's some really fantastic opportunities in this space. Local government reorganisation also brings a great opportunity in terms of thinking about some streamlining of some of the things we currently have to do several times, thinking about our influence in planning, for example. But that also comes with challenges and new relationships, challenges to the partnerships, like Carol said, and also integrated neighbourhood working, integrated neighbourhood public service. How do we bring the building blocks of health into those spaces? How are we bringing to life that stuff that our colleagues from Bellamy were just talking about? How do we make sure that that's living, breathing through all our different neighbourhoods, and how can we bring that forward? So you'll see on that slide there's some projects broken down by building block, but really there is that kind of broader strategic overarching arm as well that we'll be working towards across as a system partnership. So I think that's everything from me, and there's a few asks from the board in terms of thinking about how we're continuing to engage through making every contact count. So through those healthy conversations, how are we supporting and signposting people to support their building blocks of health? Embedding our Nottinghamshire spatial planning and health framework and our health impact assessments. We've generally got very good engagement on this from most districts and boroughs, but there's always more we could be doing. So we're going to keep working towards that. As Carol mentioned, continuing that partnership space, and a question for us in the future as a broader group to think about how are we better funders to the voluntary community sector. So thinking about how are we preventing this kind of short-termist approach to the voluntary community sector and bringing them in as broader partners within our integrated neighbourhood approach. Thank you.
Wow. That was a tour de force would be the only thing you would say. So I'm really grateful to Carol, Ellie, Leslie and Sally for that. If we could get the funding secured on a longer term basis, be it through the Better Care Fund or however that may be, and if we could get scalability, whereby we could take the work that's done, see the effect it has, and then scale it over a larger area, that would be the desirable thing to happen. Bellamy, I've not been to Bellamy, but I feel like I've lived there. I've heard so much about it over the last number of years. And you had it up there about green fields in 2016, 2017, which I think is when Active Nuts went in there and started to try and create a change in people's. I think what you're highlighting is the typical medical model that we've relied on for so many years to actually keep everybody safe and well, where we expect them to act in a way which people have traditionally done. We expect them to go and get their children vaccinated just because we say it's the right thing to do. And why is society, etc., and vaccinations failing? Because people no longer believe in that model, and they need a more social intervention. They need more direct contact to understand the reasons for their behaviour, why they choose to do the things they do, and it's only at that level that we'll start to make the breakthroughs that we are hoping to make based on a model very similar to your own. I'm going to open that up to the room, and I'm going to ask the Director of Public Health, Vivian Robbins. Vivian.
Thank you, Mr. Dorian, and thank you, colleagues. That was a really fantastic presentation, so thank you all. A couple of points from me, really. I think, first of all, what you've highlighted there is the opportunity around neighbourhood working, and we've got further sessions, we've got a discussion later on in this board, but then a working workshop later on this afternoon to really unpick around what is our vision and what are the priorities around integrated neighbourhood public service. And I think what you've articulated there is the real importance around building on those building blocks of health and well-being, and how we can genuinely wrap around people who have a number of barriers in a slightly different way. So I suppose I'd be really keen to think as we think around those things in broad, how do we take in some of the messages that you articulated? And I think the key things that I wrote down was one around one place, thinking around how do we allow communities to thrive, relationships and confidence in the staff in those places. So and some of those are not as tangible as others, and I think we need to be clear around how we bring some of those in. And the other thing for me was thinking around what other opportunities we've got, and Council of Justice will be aware in terms of some of the work we're doing around looking at some further opportunities we've got with the Crisis Resilience Fund, which is a national fund that will be moved through County Council, and we're just looking at how do we make sure that we've got a more sustainable approach to supporting families, particularly of low income, but also that have a number of barriers. And I think some of the things that you've articulated there are really important areas that we need to consider there. And we're also looking at reviewing the Local Communities Fund. So how do we get even more value and even more impact from a really important funding approach there. And then my final point was just linking into our colleagues from EMCA. Thanks, Matt, for coming today. And I think we really need to not underestimate the opportunity that we had. Matt and I were at a conversation with EMCA directors yesterday around really thinking around how do we embed that health in all policies approach, but also that equity in all policies approach. And obviously the Bellamy estate is a really important example of where we have some of our deprived communities. So I'd be really keen to think around, Matt, how do we further explore that? How do we build that into some of the EMCA priorities? And how do we strengthen those relationships? You know, really thinking from that grassroots and that hyper-local level, but right up to that regional level, the opportunities of EMCA, but also thinking, Alex, the opportunities from an RCB point of view. That's it for me. Thank you.
Thank you. And as you rightly say, the concept of tangibility and end points are not necessarily the new world that we're emerging into, and we're more on a journey rather than looking for specific ends in that. And that can be quite difficult to accept in a world where we like certainty and definitely. I'm going to ask Professor Daniel King. Daniel.
No, thank you. That was a really inspiring sort of talk you gave, and I've heard quite a lot already, Leslie, about Bevan instead. I think you really brought it to life. So 3 key things there. I think the first one is just thinking about the evaluation that you're talking about, and I think that's really, really important, is can we capture so it feels like there's a few elements. What are the things of the model that are working, and trying to understand some of those key things? Trust seems to me actually a really key underpinning part of this. So some of this is quite hard to intangibly measure, but actually we don't need to measure everything, because some things also we know from literature and other things like that work. And you also talked about the funding surroundings and the way it's commissioned as well, and just really encourage that could be part of the evaluation sort of thing, and trying to, rather than make it a summative evaluation, could we make it more a learning evaluation as well? So the evaluation can be taken on, and what are the key principles that could be embedded into other funding opportunities as well. Having done various bits of evaluation for government and other things like that, the major thing I was thinking with evaluation is they may end up sitting on a shelf. How can we make sure actually this evaluation gets embedded into future funding things, so that then we pick the learning, so that any other funds comes along, we look at the evaluation that you're doing and we learn those key lessons. That'd be one thing. The second thing you talked about, I think, on that, and the request around sort of support for funding as well. There's a couple of things that, very much, of course, support that as an idea. There's the Civil Society Covenant framework that DCMS have fairly recently put out, which is trying to create a different relationship between the voluntary sector and different areas of local and national government as well. So I suggest that would be something really worth looking at. And a number of us, Andrew and I and others, have been part of a third sector commissioning group as well, trying locally to try and work out what that is, and I can put you in contact. So let's think about some good principles that's there. And actually, this is maybe something for the health and movement, not just to be able to say, oh, we support this, but actually, can we find some tangible things that we say we could do, given obviously the funding difficulties there. And the final thing, just relating to what Councillor Doddy said, I think this is a brilliant idea of the social model of this, and actually championing up examples of that I think are really important to bring that thing to life. So we talk about these as conceptual things. I think this is a really nice, concrete, grounded example of that. So showcasing that to other places also feels really important to me.
Thank you, Daniel. Councillor Wilmot.
First of all, can I congratulate the presentation? It's absolutely fantastic. It's just so many projects that it's absolutely mind-boggling, and just hope that they haven't taken on too much at this present time, and they are going to prioritise the ones that are needed to be put forward straight away, and those that can wait just a little bit longer. As I say, I realise the amount of work that's been done into this strategy, but now you say that you would like to create a society where everyone thrives. That includes stable jobs, good pay, quality housing and education. But don't you think that's going to be a little bit difficult? The opportunities being reduced through the rise of national insurance contributions and many other rises as far as the jobs are concerned. There are serious areas of deprivation in all areas at the present time. How many available jobs, the amount of available jobs that are available are very often very much low pay, which is also going to be a severe problem. And obtaining quality housing for young families is almost impossible, with thousands on the council waiting list and private rented accommodation rents going up through the roof at present. And of course, the cost of buying a property for a family is steadily rising to a cost which is out of the price bracket of many first-time buyers. In key achievements in the 25-26, you put down improving access and affordability through food distribution schemes via the local community fund. I feel that many of the constituents, unfortunately, are saying to me that it's barely touching the problem, as food prices continue to rise everywhere, I welcome the work done at the trial court on the Bellamy estate. That really is fantastic. I noticed you mentioned Coxmore in your report as well, but it's essential that you get onto other areas as soon as it's possible, as soon as you find out what the problem is. But the major question is there money in the budget to do it? That's the question you've got to ask. And looking at the outcomes in Ambition 2 on page 36, it seems that we have similar outcomes to England. However, none of the trends are showing improvement. I just wondered when is any improvement expected in that situation? Because if you look right through the whole lot, they're either the same or they've dropped. And that is concerning, got to be concerning, get all of us. And also, I say, and now looking at the rest of the indicators, there's loads of other indicators. A number are still concerning, very concerning. How can we, or when will we expect some improvements on these? Thank you very much.
Thank you, Councillor Wilmot. It's probably not inopportune that you're going to be followed by MCA representative Matt, and Matt will tell us how we're going to get MCA getting everybody to 80% of the available workforce in employment. They'll tell us how we're going to build 100,000 houses across the enterprise. They'll tell us how we're all going to go on what is known as the opportunity escalator, and how he's going to narrow the gradient of inequality. You're quite right, Councillor Wilmot. Scalability, as I said to begin with, and funding, as always, will be the key things. But what we're doing is we've moved into a whole new world, and that world isn't just the Health Development Board, it isn't just the Bellamy Estate, it's MCA, it's the Better Care Fund, which we're going to spend quite a bit of time on going forward, how that's got to £10 billion over England in order to facilitate the preventative agenda along with its existing agenda. And I'm going to say over to you.
Thank you very much, Councillor Doddy. I'd love to say we'll solve all of those things and deliver them by Friday and then move on to the next round. But I will say a bit about what we're trying to do and how we can support some of this. I'm really pleased that you mentioned that you're already working with anchor colleagues on this. There were a few things I was going to say specifically on the Bellamy model that you just described, and then I'll pick up some of those wider points as well. So I think, as you were speaking through, I was thinking there's three things in particular I'm really keen that MCA does around supporting the Bellamy model, picking up on the conversation that Viv and I had with MCA directors yesterday. So one is, as you say, those wider social barriers, those social areas where MCA has levers. You mentioned employment and you mentioned housing. So if there are others where we have levers around things like transport, around economic growth, for example, let's think about those and figure out how we can support the model and look at the ways that we can support those wider barriers that people have. So really keen to pick up a conversation with that. It sounds like you're already talking to a lot of the right people in MCA, which is brilliant. But if there are more connections that we need to make, then let's link you up with those. The second is funding, and I think this maybe picks up on some of the wider points as well. We are looking at how we structure the funding that we're getting in from central government, including the local growth fund that we've been awarded, which gives us over £100 million over the next 4 years to focus on growth. We're really keen that we don't just focus that on the obvious things of let's just funnel that into business support and getting those big tech industries into the region. We want to think really carefully about how we use that fund to support places and to support some of the wider barriers to people getting access to employment and economic opportunity across the region as well. So as part of that fund, we're looking at how do we carve out a section on communities, on healthy places, on healthy living, and let's figure out how we can use some of that. I don't want to jump ahead and say that automatically means that we'll suddenly have a load of funding at our disposal on this, but we want to really think about how we structure our funding model to support initiatives such as this one and support the social aspect of how people benefit from economic growth, not just supporting the business side of things. And then the third point I was going to pick up on was the point on scalability, and I'm interested in that obviously from an MCA-wide footprint as well. So thinking, what can we learn from this model that applies maybe not just in other parts of Nottinghamshire, but across Derbyshire and other parts of our wider region as well. And similarly, I've come across similar models of that one-stop shop model where you bring people in, you have all the services that they can benefit from together, so you can do the warm handover. So if other areas are doing things similar to Bellamy, let's lift them up and let's try and join some of those initiatives up where we can as well. So those are the things I was going to say on the Bellamy model specifically. In terms of the wider points and the wider things that MCA is looking to do as well, You mentioned our 80% employment target. We have a Get East Midlands working plan, part of which, a big part of which we're trying to focus on is on the health side, and we're working with ICB colleagues around how can we commission employment programmes and health programmes jointly, so that we're linking the employment and the health outcomes together. We're not treating them as separate silos. So I think that's one really key lever we have. And we're also looking at how do we develop our opportunity escalator model off the back of the inclusive growth framework to make the most of the fact that MCA has all these levers. So economy, employment, health, transport, all of the things that affect the wider building blocks of health. And that was very much the theme of the conversation Viv and I had with MCA directors as well. How do we make sure we don't think of those things all in silos, we actually join them all up so that the things MCA is doing is having a direct impact on health as well.
Thank you very much, Matt. And obviously, as you bring people into employment, obviously as we raise the salaries of the lowest paid, this is the most effective way of narrowing the gradient of inequality. I've got 3 more speakers, Andrea Birch, Helen Smith and Calvin Wright. I'm going to start with Andrea. Thank you.
Thank you. Thank you. A lot of what I was going to say has already been said, so thank you. I'm very appreciative. But my first thing to say was a thank you. I'm here with my place hat on for Bassett Law, but also as part of our sector, we, as you know, there's another area in Manton, very similar model, and I have to say, of all the funders we deal with, the public health team and the Investing in Communities team were absolutely fantastic. They get it. The integration across that approach of recognising the building blocks of health don't sit in isolation, they work together, has really accelerated the understanding of our place and the way that we work together. So thank you to the team, and also a thank you to Leslie, because she's a real champion across our sector. When I first came into the sector 25 years ago, there she was at MCVS, and she's still there. So she's at the heart of the Mansfield communities and worked to make all yes, you were in short socks, weren't you? But yeah, it's a small world, the voluntary sector, but we're very passionate about it, and it's been a fantastic programme. So lots of learning to take forward. The last point, I think, is that it's important to recognise our job as stakeholders, whether we're voluntary sector or public sector, is to hide the wiring in terms of funding. Citizens, community members don't care where the funding is coming from. They care that there's consistency, they can access the right people at the right time, people and faces that they recognise and trust, and that is our job to make sure that happens. The rest of it is all noise, and that programme has done it really successfully. So there's loads of learning to share in future programmes, and thank you to everybody that's been involved.
Yeah, agreed entirely. Thanks very much, Andrea. Helen.
Andrea, I think you've said all that I was going to say as well. A big thank you in terms of the way the funding has been organised. I think it's allowed us to build on what's already working rather than starting afresh again, and particularly with the communities that we've been working with this funding, that's been so important. And I also was going to say about Leslie, you know, when we did the NHSEI work on Bellamy, Leslie was there, so she's been a continuum, and that continuum of trust has allowed all this to really happen. So I wanted to acknowledge that. One thing that's quite interesting that's the same in all the areas that I think we've been working with is the health service bit, in that often these estates are served by different practices or different primary care networks, and this sort of the barriers of, oh, we can't do that because we don't serve everyone, or what if we see some, that is a real issue, and I think that would be really useful to sort of explore further. And similarly, the payment mechanisms to allow community health providers to just do outreach work rather than tick their activity box, which is what they're commissioned to do. There's different levers I think that we could do and serve these communities much better. My final point is in terms of NHS Talking Therapies and Wellness in Mind, because they're both services that are everywhere, and just checking if they've been part of the work in the estate. That would be interesting. And again, just to also acknowledge citizens' advice. We're really feeling the benefit of colleagues working in our integrated neighbourhood teams, and that real sense of team of teams is really coming together, and that's coming through physically being in the same place and building those trusted relationships. So,
thanks very much indeed, Helen. Wait till we get the onset of the first integrated health organisation where the first hospital takes over the GP contracts in the premises and starts to provide secondary care and primary care through one vehicle. Then you will get proper joined up care. Councillor Wright.
John, thank you. I just wanted to return to a couple of the outcome measures actually of interest, and perhaps give a plug for an area which I know is dear to both your and my heart. So when you look at the outcome measures, it's interesting because the abdominal aortic aneurysm screening and the newborn screening and the teeth are much better than the national average. So it suggests to me that the engagement with health is good. However, everything in the vaccination column is on a downward trend, and is in fact, I don't think any of those hit the standard for herd immunity. And I therefore think that has got to be an area we should be working on. And whether it's education, whether it's post-COVID and the conspiracy theorists, whatever, we need to unpick and undo. But vaccination is clearly an area which is we're failing on, sadly. And like I say, we've got to hit the herd immunity targets. So that just stands out for me from the data, that was all.
Yes, Councillor Wright. Understanding vaccine hesitancy is the secret to increasing levels to herd immunity. And if you put a vaccine mobile centre at the end of the Bellamy estate, if the people don't actually want to go and be vaccinated, then it doesn't matter how beautiful that bus is or how fantastic the staff are, they're not going to come and use it. So you have to understand the cause of the hesitancy to address the anxieties or the beliefs or the traditions of that particular group of people in order to be able to achieve those goals. And I think that's the type of communities and neighbourhoods that we're aiming for. Thanks very much indeed. I think I feel like I've had a workshop. That was unbelievable. We could have gone on all afternoon. I'm going to move to recommendations that we note the update on the Q3 delivery of the Joint Health and Wellbeing Strategy 2025-2026. Received the presentations that was done, which were absolutely brilliant, and consider opportunities, escalations highlighted in paragraphs 14 to 18. I move the vote. All those in favour? Yep, fantastic. Now we're going to move briefly on. If we keep going at this pace, I think we should be here till midnight, and we'll need more than biscuits. I can tell you. Item number 5 is the Better Care Fund. The Better Care Fund often perhaps lacking some of the great attractions of other items, but all that going to change over the next year or so when the 10 billion of funding, 7 billion for the NHS, 3 billion for local government is released, and we get the opportunity not only to do the traditional things that we've been looking at, not only to look at the discharge to hospitals, preventing people going into care, etc. But we also get the introduction of how we're going to move from disease to prevention, and that's the thing that we've all been waiting with bated breath for, to see what could the vehicle be. And I think there's no better vehicle than the Better Care Fund. With regards to the Better Care Fund, I'm going to pass over to Anna Oliver. Thank you, Anna.
It's not actually me today. I don't have to go for a change.
Actually, I said I'd taken forward. Afternoon, everybody. I'm Gavin Dictor, Executive Director for Adult Social Care. I'm afraid this item isn't as item as the previous item, but this report provides the board with an update on the delivery of the performance of the Better Care Fund across Nottinghamshire, specifically for quarter 3. And as was the case in the last meeting, you were asked as the board to ratify this. That's already completed. The template for NHS was submitted on 30th of January. Unfortunately, this always happens where we have to submit the data to NHSE before we can get it to the board. But this Better Care Fund remains a key mechanism for supporting the integration of health and social care locally, bringing together the funding from the County Council and the NHS as support services that promote independence, prevent avoidable hospital admissions, and enable people to return home safely and quickly following their stay at hospital. And in the context of sort of increasing demand across both health and social care, the Better Fund continues to play a really important part in the supporting collaborative working across the system. It helps partners focus on our shared priorities such as strengthening community-based support, improving those hospital discharge pathways and ensuring that people receive care in the most appropriate setting. The report outlines the current performance against the National Better Care Fund metrics alongside progress in delivering the priorities set out in our local plan. And whilst the system continues to operate in a challenging environment, the Better Care Fund remains an important platform for partnership working and for supporting the wider ambitions to deliver more integrated person-centred services to residents across Nottinghamshire. I'm grateful for the continued oversight and support the Health and Wellbeing Board gives to this, and I'm hoping that you can, the board agree to ratify the report. Thank you.
Yes, thank you very much indeed, Guy. Great challenges across all sectors, be they emergency admissions, as in non-elective, be they delays in discharge, be they residential admissions, all difficult to keep on track. And I believe that over time, the government is going to be looking for 2% year-on-year efficiency improvements, etc., as a result of Better Care Fund, etc., and how we're going to work together, the ICB and Alex for the team and the local authorities in order to achieve the goals that we want to, including prevention, including finding the monies to allow us to divert from disease to prevention. So quite an increased demand going to be required through the integrated neighbourhood teams via the Better Care Fund to improve all of these indices that you've laid out before us today. As somebody who looks after adult social care, it's your area, it's your ballpark. What's going to happen?
What's going to happen specifically about
the world in general. But if you could confine yourself to adult social care, getting the discharges up, cutting down the unnecessary unscheduled admissions, and moving the agenda.
We talk a lot about discharge, don't we? Actually, what we want to do is prevent people needing to go into hospital in the first place, really. So that whole thing about what happens in communities at a local level is the think about the neighbourhood plans is really where we want to go with. Actually, most people, I always say the only bed that people really want to be in is their own bed, really, because actually it's disturbing for people when they're not in their own bed, and it's confusing for some people. I think the Better Care Fund has been a real brilliant way of actually how we can get integrated working together and actually pooling money together across health and social care. So actually, I've worked in other places where we've been able to pull more money into a Better Care Fund under Section 75, which allows us to simplify the way we can get money into a joint effort into doing things for people. It's not just adults, it's also children. So it's about what we do with children and family across those outcomes that we're trying to achieve. Some of these things that we're doing now start in childhood, start with families much earlier on. So I'd expect our neighbourhood planning to think about how we're going to start preventing some of those things coming through into adult social care at a later date. And I always still say as well, we don't want people to live in residential care, particularly when they're younger adults. The opportunities that are not afforded to them by living in residential care, they don't have the same relationships with other people. They don't have the same outcomes in terms of being able to go into education or go into employment. So there are a number of shifts that we need to make in terms of the health and care system that would enable us to get better outcomes and have more better quality of life for people for longer.
Thank you. Vivian Robbins.
Thank you, Chair. So I suppose just building on a couple of points there, I think the unique selling point that we've got is this Health and Wellbeing Board is to support the broader ambitions around the BCF in terms of how do we stop people having those emergency admissions in the first place. And I think when we think around the causes of the causes, it goes back a lot to the building blocks conversation that we've just had. So if people have the right accommodation that supports their needs, they'll be at less risk of having a triple or a four, for example, which may mean they have that emergency admission that we wouldn't want them to have. And then we know that if once they're in hospital, if they're in for a long period of time, then that's when they can have poorer outcomes and that steeper deterioration of their health. So, but I suppose there is something for me to think around in terms of how do we link up all of these bits into our ambition around integrated neighbourhood public service, and really genuinely thinking broader around our opportunities. And I think, as Guy articulates there, we've got a very good BCF at the moment, but are there broader opportunities that we would like to think around? And I know there's lots of conversations around different transformation funds and things like that we've got, and I'd just be really keen to think around how are we really thinking a little bit more outside the box, and not necessarily just thinking around those clinical pathways. You know, Damien will talk a lot around some of the visits that the fire service will go out to meet those vulnerable individuals. Well, they will be some of the people that are in our most deprived areas that have severe multiple disadvantage, that are also those people that are at highest risk of emergency admissions and hospital admissions. So I suppose there's just something to think around in terms of how are we connecting all of these dots, and how are we utilising this investment.
Thank you. Keeping people safely in their own homes for as long as possible. I'm going to, because we'll be discussing this later on, I'm going to move to the recommendation that we ratify the completed Nottingham Better Care Fund 2025-2026 Q3 7. All those in favour? Fantastic. So we're moving on now to item number 6. And item number 6 is almost like an expansion on the conversations that we've already been having, and it's a report on the Integrated Neighbourhood Public Services, the INPS, and the progress of our neighbourhood plan. Vivian Robbins.
Thank you, Councillor Dolly. So I won't go into too much detail with this, because I think this is just really an update in terms of where are we at. So we've had quite a lot of conversations around integrated neighbourhood health, integrated neighbourhood public service, and what does that mean for Nottinghamshire. And what this paper tries to do is just articulate some of the work that we've done to date. So that colleagues are aware, following the previous board, we've had some broader conversations with the joint Health and Wellbeing Strategy Steering Group. We're expanding the remit of that steering group to make sure that that's almost some of the engine room to work behind the board in terms of developing some of the work around the integrated neighbourhood plan. And what we're trying to do is build on some of the developments of the 2 workshops that we've already had. So what you'll see in the appendix to the paper is you'll see some of the draft principles that we worked on in the last workshop. And I think we absolutely acknowledge that our thinking is evolving in this space. So they are absolutely draft principles to consider. I think there's been some really good points that have been raised today, and I think we need to challenge ourselves to think around, are they resonating? I think family has been one, having that trust, that relationship, how we're supporting our voluntary community sector. We just need to think about in terms of, are they the right principles in terms of what we've got. So I suppose I'd be really keen to hear feedback from colleagues around the table in terms of, do these feel like they're hitting the mark, or are there some areas that we would like to improve and develop on these? And then in terms of what some of the national timescales are, we were hoping that we would have planning guidance around neighbourhood, integrated neighbourhood plans. Unfortunately, that's been delayed by NHS England. We are anticipating to get that in the next month or 2.
I think imminently is the phrase that gets used.
Imminently.
Yeah.
Unfortunately, I've heard imminently for a little while. I won't say it's too soon, but hopefully soon. And then we will have that need to make sure that we do develop that integrated neighbourhood plan. And what you'll see in the paper is that we do need to make sure that we endorse that plan as a board, and make sure that it is aligning with some of the broader strategic ambitions, but also the joint health and wellbeing strategy. And you'll see there is a statement in the paper that we've previously used, and if colleagues are happy with that. And the other thing that I think is really important in here, though, is acknowledging that as much as there's a really strong health lens in terms of the integrated neighbourhood teams, there's a number of reform areas across the system that are also thinking around how do we work at that hyper-local approach. So, you know, whether that's family first partnership, whether that's police reform, you know, whether that's thinking around the central reform that's just come out, as well as local government reform. There is lots and lots of different drivers that are making us think around how we work in that hyper-local level. And I think we do need to acknowledge what as individual organisations we may have in terms of specific performance measures. I know NHS England will, I'm sure, give you some, Alex, from an ICP point of view, but also thinking around how does that build into the bigger jigsaw or ambition that we have as a broader collective approach to integrated neighbourhood working. So I think in terms of that, we're just looking for some feedback really in terms of what people think the principles are. We will be going into a workshop discussion after this meeting to really start thinking around, we've got some principles now, but what would the priorities be? And we'll be working through some different personas to think around, okay, within these individual things, what are the gaps and where do we want to prioritise our option? But in terms of the ask, we are aware that potentially timescales may not align exactly in terms of when we need to sign off the integrated neighbourhood plan and the times of the health and wellbeing board. So in terms of summing up and in terms of recommendations, we're asking for feedback on the joint principles and asking for you to continue to support and commit to the ongoing work around neighbourhood health and planning. There is that need, that ask around the board will be receiving further updates in this space. And we will need to potentially do some of that outside of board meetings depending on timescales. And then there is that ask around whether the board is happy to delegate the responsibility to sign off any particular plans that we want you to do to the Health and Wellbeing Board and myself and colleagues are happy.
Thank you for introducing the recommendations. And in Appendix 1, you can just see what the summary was around if we can have thriving communities with services.
I'm just reflecting back on what was spoken about earlier, and just picking up a couple of other key principles. It seems to me there's something about the work that Leslie's been doing. Well, Joel on the Valley Estate, you know, the long-termness of this and the embeddedness of this, and so and obviously recognising the challenging of funding rounds and NHS guidance and all these other things as well. So there's something about long-termness, consistency, and embedding within communities that I think would be really important to bring out. And I think the second thing, again, reflecting on what was spoken about before, is also how do we make sure that we are I think it's sort of implied a bit working with communities, but really understanding what is meaningful to them. Because there's talking here about working meaningfully, but I'd like to sort of work out what that looks like. And then the final thing just within this principles is, I think these are great and they're really ambitious and they're quite a big change in things. So I think there's something about working towards this and the fact that actually you're not going to achieve this overnight. It's a moving in a direction of this sort of thing as well. So how do we make sure that we don't give up when things go wrong? Sort of principle. So it's actually always working to aspire to things, even if we don't hit them now. But I'm sure you can articulate them in better ways in the document.
Thank you, Daniel. Go ahead.
I'm sitting in the wrong, sorry, sitting in the wrong place. And I'm always going to speak into Daniel because you say so many words. Just absolutely agree with what Daniel said, but I'd add to that investment upstream in prevention will achieve the outcomes we want, that long-term outcome in terms of reducing non-elective admissions and the pressure on rescues. So yeah, everything Daniel said plus investment as a principle.
Guy.
Thank you, Chair. And likewise, as people have said, I think they're ambitious. I think there's something for me about this is a sort of what's an opportunity to actually stand back from some of the things that we've been doing and actually thinking about. I think when I hear other people talk about stuff in the community, I think about things around simplicity. I think sometimes we've overlaid things over years, and actually sometimes we need to step back and think actually how we overcomplicated things for people is access to things so difficult now that actually we're not getting to the right people at the right time. Some of those things I think about having agility, simplification, stepping back, thinking about the impacts, much more what we need to see in the future as opposed to what we properly in the last few years. I pick up that point, I think the co-production bit, but communities. So I think there's a difference between having a high set of principles, but actually within those neighbourhoods, they can have a local set of principles that are co-produced with residents as well.
Councillor Wilmot.
Yeah, just a quick one, Chair. On page 69, it shows all the draft joint principles for the integrated neighbourhood working. I just wondered when will we come back to us with some of the issues and how they're progressing, and how is it going to be monitored, and how are you going to get the message out to the residents? Just wondered, if that had been sorted out.
Vivian Robbins to answer.
So I'm just writing down your questions there, Councillor. So in terms of how will this be monitored, I think that's for us to shape. So we're really in the infancy in terms of defining what we want to deliver. But I think as part of that, as we develop the integrated neighbourhood plan, within that we will articulate what we think the evaluation framework is. And I think Daniel's points earlier around the different types of evaluation here, and Carol's articulated some of the challenges around how you evaluate some of the work in this space is going to be really important. And there will be an element of we're going to have to test and learn some of this. Some of this we're already testing and learning, but some of this we're going to have to be brave to test it. But also, if it's not working, think around how we change direction. And so that links into your point around agility there. In terms of messages out to communities, I think once we've got almost a broader strategic framework, we will then need to think around where do we prioritise going and having those conversations with communities in communities. Because I think the work that we've seen on the Bellamy estate here is actually, you gave the example around what they needed was support to help fill out the forms because they were struggling with that. Well, we wouldn't know that unless we actually went and spoke to them. And we've got to absolutely acknowledge that the needs and the wants for one community are going to be different to others. So there's something around how do we build a model that has some broad strategic framework and lenses on, but allows that really local flexibility. And I think that's some of the things that we're going to have to grapple with, and that's some of the things I'll be keen to unpick in the workshop. But we're very much at the early stages of this. So it's within our gift to think around how we want to shape it and how we want to evaluate it moving forward. Did I cover all your points there?
So I think this is really helpful. It's obviously been really beneficial from a number of kind of workshops and conversations previously. I do wonder on the principles if there just needs to be a tiny bit of teasing apart in principle 1 and principle 2. So principle 2 talks about effectively kind of organisations, I think, working together, but then talks about co-production. We might need co-design there, and then the co-production piece can move into principle 1. So effectively for me, principle 1, which is rightly number 1, is about working with and creating with our populations what they want to see. And then I think principle 2 is then the idea of trying to put apart our organisational boundaries and work together to then co-design and deliver what's needed from principle 1, if that makes sense. And I might be dancing on the head of a pin there, but I do think it's important we tease apart co-production and co-design and engagement because they're all slightly different things. But yeah, that is probably nitpicking. I think that's really helpful. It's really frustrating that the guidance hasn't come from NHS England yet. And so, yeah, it'll come when it'll come. But I guess what I'd say is I don't think we need to wait too much because we know what needs to be done. And we're doing a lot of it in a lot of places already. So hopefully some of that will come out of the workshop in a bit. And then there is something about also where we really want to prioritise our efforts. And I think your point's well made, Viv, there. From a population health point of view, the ICB has got a view sort of grounded in evidence of where our priority neighbourhoods should be. But we'll then want to layer that in with kind of other evidence and other data and other priorities, because I think getting really clear about where different organisations and different partnerships will want to prioritise their efforts will be really important as well, because we've got the resources we've got, which are quite considerable, but we've got to make sure we invest them in the right places so there's no duplication and we're maximising our efforts. So I think we do know what needs to be done. we might need to tweak it a bit with some guidance. I think it's more interesting actually about for what and where we might need to deploy our activities. I think that's the key bit that's next.
Thanks, Alex. And dancing on the head of that pin about co-design, people who are involved in the design always like to see their end product. They like to see what you produce with the co-design and to be on board to make the alterations that are required when you have to make those changes and keep it online. Damien West.
Thank you, Chair. I'm sort of in no man's land between speakers, so apologies, but thank you. I think just to build on that point and the point that Viv made earlier, I speak on behalf of Fire, obviously, at this arena, but in terms of those principles around, especially number 2, that co-design and co-production, as Alex says, I think that broadest sense of engagement with partners is great for us to have a place at this table, but all of the partners that I meet with regularly who aren't represented here are also trying to engage with these communities. And if we are putting it community centred at the heart of it, that community, I'm sure, will just want the least number of engagements to get the best quality outcomes. So I think, great set of principles. I agree. I don't think anyone can disagree with what's there. I think particularly as we build on those principles and as we look through to delivery, understanding which partners can have an impact on health outcomes that aren't necessarily health orientated, but also if we continue that community focus, but in its broadest sense for all the partners that are engaging, because I think that's the best way we can have that impact.
Can I just get you to expand on the partners that you feel that are out there that are not here? Thank you.
Yeah, absolutely. So I met last week with the Department for Work and Pensions. It sounded like exactly the same conversation that was being had about the Belmere estate, in that they're really struggling to engage with people still around single benefits and people accessing those sorts of things. They're exactly the same demographic that I'm trying to target for preventable death in the home. And I think that there's lots more, so I'm more than happy to share more information you can pick up in the workshop and bits like that. But that's just one example off the top of my head.
Yeah, fantastic, thanks. Guy, did you actually want to come in at that stage?
Yeah, thank you. I think what we've got to get better at, we talked a lot about prioritisation, but actually the opposite of prioritisation is deprioritising other areas, and actually that's hard and difficult and it's not always well received, but I think that's something that we've got to explore, because actually there is only so much resource, whether that's people or money, and then if you're going to try and hit the right things, we need to be able to move that around. So I think the braveness in it is about actually having those conversations about what isn't having the impact and what can we do differently to actually make a bigger impact. So there's a real power shift. I think if we've learned anything from integration, health and social care, everybody has to give up a bit in order to make something different. And that's all be the same in the neighbourhoods as well. So you can only do that collectively, but you have to be able to have those conversations about, we will decommission some things, we will have to invest in some new things. That's because we want to get better outcomes than we've got already.
And I'm going to take one further contribution.
Thank you. I just want to start on Damien's point. I thought it was a really, really good one. So apart from saying Matt's your world expert in how to work with DWP, I'm sure he'll be very happy to help with. I think that's exactly right, Damien. And we need to be careful which end of the telescope we're looking at this from, but from a kind of health point of view, we've started to develop a bit of taxonomy around activities which should be a health lead, activities which should be health in partnership with others, and then activities which we will absolutely support but might be kind of sort of waving encouragingly from the sidelines. And that's okay, isn't it? It's when we kind of put things in the wrong column or think we're in one column and we actually should be in another column that there's a problem. So having a really straight and honest conversation and agreeing to disagree, but at least not trying to cross over or under or overlap with people. Because again, we've only got the resources we've got, albeit they are considerable. So let's make sure we're doing stuff as efficiently as possible.
Thank you. I can say that we will be coming back in great detail to all of these points between 3 o'clock and 5 o'clock. I move the recommendations. All those in favour? Thank you. I'm going to move on now to item number 7. Item number 7 is a joint strategic needs assessment, and we're looking at across Nottingham and Nottinghamshire. So this is a strategy over both of those looking at learning disabilities, and most notably the fact that there's nearly 8,000 learning disability people registered, 30% in the city, 70% in the county, 60% men, 40% women, and we'll learn exactly what the definition of a learning disability is. And I'm going to pass it over to James Wheat. Thank you, James.
Thank you very much, Councillor Duddy. So just as you mentioned, I think what's really important is we used to do these chapters separately, and of course that has limitations. So as a system, we've worked, I think, a bit more smartly. So Nottingham City Council, the County Council, the LCB and the Trust have worked together to produce a singular Judge Strategic Needs Assessment. And I know you've got access to the full report. I just want to highlight some of the key kind of findings, and I share my view that they're very important. So if you could just, I'm so sorry who's doing it, if you could just, thank you. So just in terms of the population, you've stolen my thunder a bit there, Councillor Hardy, as you can see. So there's, yeah, just about 8,000 people registered with the learning disability in Nottinghamshire. We know 71% of those in the county, are predominantly male, so 61% male. And importantly, evidence seems to suggest 37%, so that is higher than the general population who live in deprived areas in season deprivation. And it approximately is about 2% of your national population will be adults with learning disability. And importantly, as the report sets out, about a third of everyone with learning disability will also be autistic in terms of their diagnostic profile. On the next slide, it teases out just, I think, some of the really key inequalities in terms of the overview. So what we know is 42% of deaths are considered avoidable. Just wrestling with that seems a very significant figure, and so the authors of this report tried to scrutinise a little bit more around what does that mean. So there was a leader programme and recommendations where there was a learning through that. So there's a programme which is well established locally. You know, circulatory, respiratory and cancer make up the lead causes of death. Life expectancy, as you can see on the screen, is staggeringly different as well, so 62 against 82 and it's 60 men and female respectively. And we also know, and I think it's important when we talk to people with learning disabilities, this comes out quite a lot. This isn't around, I have a learning disability different, I have lots of support needs, but it's usually a precursor for people who have correlatory support. So you can see here there's common co-occurring conditions, which include epilepsy, dysphagia, ADHD, autism, and mental ill health. On the next screen, just talks through again, so you can see some of those inequalities in a bit more detail. So 30% update locally in terms of cancer screening, 70% of the general population. Employment, I heard earlier today about the importance of employment and kind of meaning in your community. Locally, 2% of adults with learning disability will be in paid employment. Just as a caveat to this data, it's sometimes really difficult to compare like for like. So some systems have volunteering and employment, and this is an employment as in paid employment. So sometimes you're not quite comparing like for like, but there is significant difference. Again, housing. So we know lots of people, so 22 to 24%, live in unsettled accommodation. The transitions, we know, as the report sets out, there are sometimes real pronounced challenges of those individuals who are moving from children's services into transitioning into adult services. Probably a well-discussed issue in the report sets out that remains an issue locally and nationally. And we know that there's some groups who are either under-identified or underserved within the learning disability population itself, as the report sets out. On the next slide, our health colleagues have helped us to better understand. So 40% of everybody with a learning disability who requires support will have a co-occurring mental health condition. So when we talk about kind of mental health and learning disability being separate, I think the evidence seems to suggest that's not indeed the case. And so the recommendations intend to think through what that means. We often have symptoms often misattributed to their learning disability. So you may consider that that's behavioural, that's just someone's behaviour because of their communication with the learning disability, as opposed to the diagnosis or the support they may require clinically. The report reflects there is a need for specialist, trauma-informed and accessible mental health services. And if you think about the step above, 40% of people with learning disability is their mental health, is their primary support need, not their learning disability. And linked to that, the training for staff and the improved assessment is essential. That's a national position, but it's also very much identified locally. There's a few more slides. I'll just get to the next one. Thank you. An important observation within the report was that 1 in 5 people with a learning disability, age 65, will develop dementia, which is about 5 times higher than the general population. And what we also know is, which is quite positive, very positive, adults with learning disability are living longer nationally, less data locally, but the national picture is people will continue to live longer, which is fantastic. But it also means that potentially their needs are likely to adjust to more age-related support needs. We know that these statistics are even higher in terms of the prevalence of adults with Down syndrome. So the report again recognises that we have lots of really capable learning disability services. We have lots of opportunities, support and services for dementia, but the joining of those two kind of worlds is probably not as advanced locally as we would like it to be. So there are clear examples of adults who potentially require service-led support and learning disability, and when it transitions to dementia, there are some gaps in terms of provision, understanding, accessible communication, and I think at the heart of that is focus on dignity, familiarity, and emotional well-being. And I think it's important to just reflect that that's obviously a lot of the challenges, and I think it's really important. Hopefully, people are cited to those. As a service and as a local system, there are lots of facets which I think are really well established, as the report seems to suggest. So our annual health checks, an 82% uptake region, which is above national average. It's really important, so adults with a learning disability should go and get their annual health check as a local authority. We really try and work with our partners, our service providers, to try and influence that and encourage wherever possible for that to take place. It's a really important step, as the evidence sets out. The leader review, so that's where there is those system reviews where there has been a death with an adult with a learning disability. We have a very well established programme locally, really strong uptake from a wide range of partners with different expertise. We have lots of examples where there's local activity. I guess we heard earlier in this board hearing, but we have really good examples where there are community-based activity and community network, which is providing meaningful day opportunities and support outside of the traditional commission support someone with a learning disability may access. There are really well-established programmes to reduce the over-medication of adults with a learning disability. People may know locally, MenCap have done amazing work both nationally, locally. It's really well embedded within our system, and of course it's something all partners subscribe to. So when we commission support or work with adults who require support, that's a really important tenet, that we don't just use antipsychotic medication like those stories you may have heard many years ago. And then we just have, so where people do require more regulated support, so usually personal care. In Nottinghamshire, we have a high proportion of those services who carry a good or outstanding rating with the regulators. So what we know is, if you have a learning disability in Nottinghamshire or Nottingham and you require quite specialist support, we have a range of partners and providers who are capable to try and ensure that those needs are met. And the recommendations, I know I've got a copy of these, so I won't read them out, maybe please. If we go to the next slide, excuse me. Just in terms of the key next steps, so there's 2 things I'd just like to encourage the board to think about how they would want to join in or participate. So we have a public webinar. We trialled this for our autism JSNA last year, and it was really successful. So we have the report authors, so that's social care and health, talk through their findings, and then a question and answer session, which was probably the most helpful bits of the autism learning. This is recorded, it will go on our public website so people can look back, and I think it brings to life, you know, a 68-page report in a little bit of a different way to enable people to access it. And then importantly, I think about those set of recommendations, this group probably doesn't need to be told, there's a real risk with the JSNA. You substantiate, yes, this is really important, and then nothing really happens. And this is a real challenge. So what we've decided to do this year as a system, we have a learning disability and autism executive board, which lots of organisations are represented on. It's chaired by the county council, and it has agreed to, for the first time, create a system learning disability strategy. And that in itself, strategy doesn't necessarily do anything, but with really clear action plans, which are public facing, they're accountable. So For example, 1 year on, what did you say you were going to do? Have you done it? And as part of that hearing that Esther Daddy mentioned earlier about the principles of co-production and making sure people feel they are valued and they see what happens as a result, and that's at the heart of that. So that's why the work's ongoing, but it won't be published till December. It'd be really easy for me as a commissioner to write strategy really quickly. It definitely wouldn't serve the needs of our learning disabled population in Nottingham and Nottinghamshire. So there's opportunity to join the webinar, and also if you wanted to be part directly in the strategy development, to share your views, or be part of working groups, there's opportunities likewise for partners to do that. I'll pass back over. Thank you.
Thank you very much indeed, James. And there's a huge amount of detail in that report, which time has precluded you from putting on slides. But I would recommend anybody to follow reading that, and also that it'll be on Nottinghamshire Insight that everybody has access to. And I think the joint strategic needs is always the first place to go to when you find out about the community. It's an interesting one where there's a degree of under-identification. When you point out the fact that this is an onset of childhood, significant disability, decreased ability to cope independently, IQ under 70, lower intellectual ability and impaired function, it's possible that the under-identification means that they're being followed up by different groups of people. So if they predominantly have a physical disability, which is being followed up by paediatricians or by hospital bases, that makes excuse that. And 82% for anything done in general practice is great. And of course, all of them will depend on carers bringing them to those appointments, generally speaking. And therefore, it is one of the most successful things that's done in general practice. The normal 40 to 74-year-old health checks are the most disciplinarily attended health checks in history. So these in themselves are exceptionally good in that sense. So I just suspect that we probably know about the 100% of them, but they're not necessarily being followed up in this particular pathway. Yeah, fantastic. I'm going to open that up and ask if we've got anybody that would like to ask questions. Councillor Wilmot.
Thank you very much, Chairman. It says in the report that 7,775 people are registered with a learning disability. I wonder if we can find out any information how many residents are not registered that have this problem. I know it's a serious situation. And where does a family member that has a problem, where does it be reported to by the family, you know, and there's someone in the household? That's an issue that I can't see where anybody is involved in that situation. How many, there's a specialist shortage of specialist deliverers in learning difficulties. Because if we really are going to do a proper job, and each school has to have one person delivering that service, and that's the only way you'll make a real difference in that situation. I know of 2 schools that I attend and they get help. They get help, but it's not when they want it all the time. You know, people hide the problem very often. They hide it, and families hide it as well. And which they shouldn't do. They should bring it out to us so we can help. We can't help anybody that doesn't let you know about it. That situation. It's good just to see that you've expanded the preventive mental health services. An issue that I've brought up on a number of occasions, as you know. It said in the report much of the mental health problems are undisdiagnosed or misdiagnosed. That's another real problem, and that's because people are having to rush through situations. They've got so many people to see, they're having to rush through the situation. So that's essential. We get more people trained up to do that job, you know. And as I say, mental health problem is a very serious situation. You can walk down your own high street and see people walking about with severe problems, and which discourages everybody, because you'd like to know whether they are getting help or not, and I don't know whether they are or not. As I say, expanding the preventative side, of course, is absolutely essential, and you only do that by going into the children's hubs, finding out all families, and making sure that I'm asking the parents, have you got a problem? Has your child got a problem? Because otherwise they're going to say many of them hide these problems, and it's a very difficult situation. Thank you.
Yes, it is a very difficult situation, and it almost mirrors the chronic mental health challenges that the mental health services has with regard to that. They're all identified as children. Part of the definition, Councillor Wilmot, is that they have to be identified in youth and then followed up throughout that. But one of the main reasons for doing the checks is that a lot of them go with undiagnosed underactive thyroids and congenital heart disease and multiple other illnesses that get picked up on these yearly checks. But sometimes one feature will be the most prominent feature. They mask other things.
Just come in just a second.
Of course you can.
You've got 12 recommendations in the report.
Yes.
I just wondered whether we're going to get any feedback from them.
I'm going to pass over to James. James.
Yeah, thank you for that question. I would be delighted to come back and give you the board would welcome that. And I think the spirit of this, I wrote the last JSNA in 2019, and sadly some of the recommendations kind of are still quite relevant. So we've had a really honest conversation as a system to work out how we can make a difference, and where we can't, we can describe the challenges or the activity which led to that. So if that could be scheduled, I'd love to come back. We will have a 1 year on review as a learning disability and autism programme, so it may well be that that would be a consistent timeline to come back and give some further information to the board. Thank you.
I've got Sarah from Health Watch. Where are you, Sarah? Down there.
Yeah. Hi, thank you, and thank you, James, for this report and the work that's been done on this. And as you just mentioned, then from 2019 to now, the fact that some of these recommendations are repeating themselves says a lot in terms of the progress we've made as a system. At Health Watch Nottinghamshire, we work and talk to patients, carers, families, and one of the most stark examples that we've received of where people are not being served by the system tend to come for people who are living with learning disability in their families. We're in a position where when we hear those things, we can go straight to those services and sort of challenge that and support that. And where we've seen real progress is where people themselves have been invited in, families have been invited in to actually support change. An example at Kingsmill, where a parent contacted us with an adult child who had a learning disability and was asked 6 times in the course of their treatment at the hospital if he had a DNR, and consistently was asked if he had a DNR, when there was absolutely no reason why this person would have a DNR and lived an incredibly fabulous life with his family and his friends. We were able to bring that to the attention of the hospital, and that family were now involved with Kingsmill in putting together training for staff on how to communicate and support families when they come into ED, for example. So, you know, this is another one of those areas that I, sitting on this panel, this group for many years, there's 2 times where I felt, blood boiling in my life. One has been when we heard from our children's services on looked after children and the expectancy of those young people, and how we as corporate parents and corporate family, I think Katie Ball gave us a really great phrase, which was, you as the local authority are corporate parents, but we as a health and wellbeing board are corporate family. The aunts and uncles are people who should look out for those individuals. And some of those statistics were some of the most gut-wrenching that I'd ever seen, and this is another one of those where we see people who are being totally underserved across our system, across this partnership of people. So I really welcome that this is the approach you're taking, James. I think the webinar, is a really useful thing to get this out to more people. And I really do look forward to that joint Nottinghamshire Learning Disability Strategy. But ensuring that the voices of people that are living with this level of being underserved is so important. And I would like to see that it doesn't take another 7 years as another report that still there are recommendations that are being repeated in this JSNA. So just want to make that point really.
Thank you. Bearing in mind, James, a lot of people are living a lot longer with these severe disabilities. Not inappropriate to go over to Guy.
Thank you, Chair. And Sarah, thank you for those comments because I think they're really important. I think we do need to be much more ambitious for people with learning disabilities. I'm really challenged the fact that we've got to talk about people as problems though, and I'm not so uncomfortable with us being comfortable just having that conversation in that way. So people with learning disabilities are very active participants of our communities, and we should treat them as such really. So, but I do think our ambitions, I think we tend to be quite, what can I say, we presented with the problem and then we try to deal with the problem, whether it be housing, whether it be social care need at that point or whatever it is. We're not necessarily thinking about the ambitions for people in their life and where they want to go and how we the stepping stones that they need to do that. And I think that's something that we've got to change as the way we operate as a service, really. I think James' work is in this, and his compassion and commitment to this is excellent, really, and I'm glad we've got him as part of the team. I think we then need to think about how we do this to children and families as well, and actually think about people as parents and all those sorts of things. So I think this is great as a first step. I think we could go further in the next year to make sure that we're looking at all people with a learning disability and take it a step further. Thank you.
Thank you, Guy. I've got two more speakers, Anne and Irene. I'm going to start with Irene.
Andrew.
Thank you. It's not often I struggle for words, but with this one I do, so I echo some of what Sarah said. As a parent, an actual parent of a 35-year-old son with learning disabilities, autism and physical disabilities, I saw him drop off the cliff at 25 where there's a lack of support. So we have real lived experience of that vacuum we fall into as an adult in this space. But on a professional note, I would say we have some fantastic charities doing amazing work in this space too. And I know you work closely with them, so please keep us around the table. Last but not least, it's the point that relates to the previous discussion too around co-design and co-production, and particularly with those that experience the most inequality. Ask once and listen, because we're tired of being asked and asked and asked and nothing changing. I'm speaking as a parent. Ask once and listen and share that insight. Don't come back to the same communities with a different pot of money or a different commissioner and ask the same questions again. Thank you.
Thank you very much. Irene? Anne?
Happy to be called Irene, so don't wait.
Irene,
Sounds like a song.
No, nice to meet you all today. I won't add too much because I think Gary more or less talked about it. James really looked forward in children's being able to join the dots a bit more. I sit here as a long-term children's person, and I know that over the years, the fact that adults with mental difficulties become parents, really, and over the years there is, it's a shocking statistic that the number of adults with mental difficulties become parents who end up not being able to parent, not because they're not able to parent, but because the system actually doesn't support the approach to some of that. So just like Gary saying, really vulnerable members of our community, loved and supported by their families, and certainly from a children's perspective, if we get it right as well as we can do in childhood and transition, we get a lot more right in adulthood. So it would have felt wrong to have not contributed to this. It's something that's really full of passion for us, because we know we can set the people off on absolutely the right path.
Thank you, Anne. I move the recommendations on page 75 that we look to learning disability in our strategic needs assessment, and we can see it on Nottinghamshire Insight. We note the linked recommendations and that you're going to bring back to a further meeting the aligned disability strategy, and I think it's been most appreciated this afternoon. James, thank you very much indeed. Right, we're almost on time. We've moved on now to item number 8, and item number 8 is the domestic abuse strategy 2026 to 2029, and I'm sure everybody's as shocked as I was when you heard that about that travel lodge that you could go in and stay in if you were suffering from domestic abuse and trying to escape from somebody, and you were handing keys out to people. It was shocking. So I'm going to pass over to our presenter of this, Amanda Fletcher.
Thanks, Chair. Thanks, colleagues. So hopefully you'll recall that at the December meeting, our last meeting, we had a deep dive into Ambition 4, which includes the domestic abuse priority. And as part of our health and wellbeing strategies delivery plan, we actually have the development and publishing of a domestic abuse strategy as one of our key actions. So the purpose of the report today is to bring this to the Health and Wellbeing Board to seek your formal endorsement, and acknowledge that we will then be developing its implementation and delivery plan. So we really welcome you to help us shape and support that. And while we're here, we'd also like to take the opportunity as a secondary ask to request that you can help promote the relevant domestic abuse training opportunities and support services that we do have across Nottinghamshire. So as a bit of background, in terms of the Domestic Abuse Act that was legislated in 2021, that placed a duty on the local authority to provide support to survivors and their children in safe accommodation. So it was very much about the accommodation-based duty, but the duty also required us to establish a local domestic abuse partnership board, undertake an accommodation needs assessment, and develop a domestic abuse strategy. So we had our first domestic abuse strategy in 2021, which took us to 2024. And then during 2025, we went through a developmental process to update and amend that new strategy. So as already mentioned, the ongoing work around this strategy and the implementation will still be brought back to the board as part of Ambition 4, keeping our communities safe and healthy. So we'll regularly be coming back to you through the lines of governance to update you on this agenda. So just to briefly talk you through the paper then, we went through a development process in 2025, and we had a dedicated workshop with system partners in the middle of the year. Very much partners wanted to align to the Nottingham and Nottinghamshire Violence Against Women and Girls strategy that was already in existence. And at that time, we also had the imminently awaited National Violence Against Women and Girls strategy. So there really was a drive then that we wanted to make sure that we did strategically align to Nottingham and Nottinghamshire system, but also what was coming down nationally. It wasn't until mid-December last year that obviously the national strategy was produced under violence against women and girls, and absolutely we already had a draft domestic abuse strategy by then, and we very much then are aligning with our strategic ambitions to what has been proposed nationally under the VOG strategy. We absolutely know that we're, as Biggs alluded to in other conversations, we're in a big system and kind of reform. So we know that obviously we needed to consult with wider partners to gain views and feedback as we were in that draft process. But also we took an opportunity, and colleagues in the room may recall that we went to our overview committee for some scrutiny around our draft strategic plan to take a range of comments, concerns or questions to help us guide us through the developmental process. So the strategy has been attached in Appendix 1, and obviously it's up there on the kind of slideshow. We absolutely want to work together with survivors and system partners to take a zero tolerance approach to domestic abuse. We've set out within the strategy our overall vision, our main aim. We're guided by what's called a coordinated community response approach, and then we've set ourselves 4 strategic ambitions. And obviously the strategy will last us for 3 years. So as you can see within the report and the strategic document, our strategic ambition number 1 is around prevention. So absolutely, how can we embed effective primary and secondary prevention work? That absolutely includes educating our children and young people, intervening early with perpetrators, and also secondary prevention to reduce repeat offences. Then we move into a strategic ambition number 2, which is about the support, so how we provide the help and support to survivors of domestic abuse and their families so that they can help to rebuild their lives. The strategic ambition number 3 is how we respond accordingly. So not only we need to safeguard and protect survivors to reduce the levels of harm, but also we need to hold perpetrators to account. And that absolutely, we work closely with the Office for the Police and Crime Commissioner around this agenda, and very much, you know, nationally we know there's lots of concerns around the criminal justice system, but helping to rebuild trust and confidence in that system, and reporting of what is such an underreported crime anyway. Strategic ambition 4 then is about how we strengthen that system, and there's kind of national best practice around that in terms of this collaborative, coordinated community response approach. So again, strengthening the system to prevent and reduce the harm caused by domestic abuse and taking that whole system approach. So in terms of governance, obviously the Domestic Abuse Partnership Board will act as a responsible body for the onward delivery and development of action plans, and obviously through our lines of governance to Health and Wellbeing Board and Safer Nottinghamshire Board, we will continually update you in terms of our delivery on this agenda. So as per the report, the next steps are that we will absolutely, this is setting our strategic aims and ambitions and our real strategic intent. We will then work together with a range of partners as part of partnership groups around developing delivery plans. We're eagerly awaiting news around funding streams, etc., that might be coming down from the National Rural Strategy and how we can implement them locally. We also, as per the scrutiny session we had at overview, it's a really difficult area to look at in terms of data and measuring impact, because it is such an underreported crime. Actually, sometimes increasing that reporting is a good thing. We're actually, you know, kind of getting the support to people that are needed, and it's showing an increased confidence in the criminal justice system and holding perpetrators to account. So we're going to set up a bit of a task and finish group around how we can consider the best ways to monitor the outcome measures, outputs or impacts of the strategy. And also to mention, we do have a co-production service that brings survivors into the work that we've done around the strategy development and the onward delivery plans. Because actually, while the data is important, actually understanding some of that qualitative aspects and listening to survivors' voices in terms of the development of the strategy, but the delivery of the strategy to make sure that we truly are making a difference to survivors' lives. So there are our next steps. Also, we will be developing a communications plan in how we kind of launch this out and get kind of the knowledge out there about what our strategic aims and ambitions and action plan is. And that's it really in terms of taking through the strategy and the work that we still plan ahead. And then just the final parts on the report talks of that second ask. So there is a range of training opportunities that are free, open to all, online and in face-to-face if needs be, through our training provider Equation. And then we've also listed the range of Nottinghamshire support services for obviously all people that we offer support to across Nottinghamshire. So there is a secondary ask there about the board taking part or promoting in the training if wanted, and helping us to promote the support services that are already out there. So I'll stop there.
Thank you very much indeed, Amanda, and you sort of encapsulated the recommendations to endorse this final draft of the domestic abuse strategy, and also to support available domestic abuse training opportunities and specialist support services across Nottinghamshire. A very important area, and I'm going to ask if anybody would like to come in. I'm going to go for the author of the report, the chair, the author. I'm going to go for Councillor Justice, whatever you may be.
Thank you, Chair, and I definitely can't take credit for that. So I'd like to thank Amanda and Rebecca for bringing this important piece of work forward.
And I know there's a tremendous lot of work has gone into this, particularly in co-production with partners and with survivors of domestic abuse, and how important that is to hear their voices. I think when you read the report, to me, that's the part that comes across the strongest when you read voices of the survivors. And you think about even small things like pet adoption, and imagine leaving with only what you've got in your car, and the things that we need to think about collectively to support people who are in that situation is perhaps one of the most important things that comes out to me in the report. The ongoing financial implications of fleeing domestic abuse. So if a survivor does get a place in a hostel, that's not the end of the story, and it's the fact that there's no real ongoing, or the amount of ongoing accommodation is difficult to find in an accommodation market and housing market where there aren't those places and the affordability isn't there for people to move on. And I think also the importance of training, which as Amanda has highlighted, is so important to all our organisations, so that frontline staff are able to recognise domestic abuse situations and have the skills to support and have that conversation with people is really important. So, thank you.
Thank you, Councillor Justice. Councillor Cooper.
Sorry to go on. Thank you. Very comprehensive report. I'd just like to echo what you were saying about the training. How about equation training? Because I've done it, and they've got lots and lots of different courses. I recently did the Understanding and Responding to Domestic Violence course recently, which is actually a whole day. As a professional that works for young people, I echo what you're saying there, because I think it'd be interesting to see how partners could actually reach out to the various youth hubs, schools, education providers, colleges, etc., in terms of actually making sure that staff on the front line are clued up in those issues around domestic violence, but also around issues around when you're dealing with people that have suffered from domestic, around trauma-informed practice as well. Thank you.
Matt.
I just wanted to highlight that from next year, as part of central government's consolidation of a whole host of grants, for the first time, MCA will be getting a grant focused on rough sleeping and domestic violence prevention as well. So this is new territory we've not operated in before, but just really keen to work with on how we can make the best use of that, particularly on the prevention side, to support the strategy too.
Vivian Robbins.
Thank you, Chair. So again, my reiterating the thanks that's already been given to the team and the system of partners that have worked with that, including the survivors, because I think we've got a really excellent piece of work here. So thank you, colleagues, for the work that you've done. And I think it's really important here when we do think around actually how prevalent we're finding this issue in our communities. You know, 1 in 5 adults in a lifetime will experience domestic abuse, and certainly until I was working in this area, I wasn't aware of that. So I think there is something to think around how we can certainly contribute on that. But I suppose one of the things I wanted to bring in here was also my Safe Nottinghamshire board hat on, in terms of really thinking around how can we work as a partnership, much more thinking around the community safety agenda, because we've had some really positive conversations in Police and Crime Commission Strategic Board fairly recently around really thinking around those causes of the causes. So we know that some of the underlying factors, that some of the building blocks that we've been talking about today will increase the risk of unfortunately families and children around domestic abuse. But I suppose I'm really keen to think around what does that mean from a health and wellbeing board context, but also how can we link with our broader partners. So the Domestic Abuse Partnership does a tremendous amount of work already, linking in with our police and our Police and Crime Commissioner colleagues, the broader voluntary and community sector. But I suppose there's something to think around how do we as a board work with that partnership more effectively and lean into that a little bit more.
Thank you. Councillor Title.
Sorry. Yeah, we've got quite a few partners actually in Rockstone working with the White River Foundation, and it's starting to be very successful. Even schools are taking it up local fire brigade have taken it up and the police force as well. So the message is actually getting out there in Broxton.
Thank you, Councillor Title. I've got two more speakers. I've got Sarah and then John Monroe. Sarah.
Thank you for that. I just want to, well, it's another one. James and I have known each other for a long time, and obviously we just talked about how long ago James was working on the last strategy and this one. I was chair of Women's Aid for 10 years up until 2008 in Nottingham, and involved in domestic abuse work for many, many years. And in that sense, it's really great to see this strategy that I feel has shifted so much in the time that I had a lot of involvement in this. And what I'm really pleased to see is much more focus on perpetrators. I think there's something here about, we talk about 1 in 5 adults of being the victims, but that means 1 in 5 adults are perpetrators. And I think the language is really important, that we turn it around, we shift the dial on the shame and the way that women particularly experience domestic abuse, and how we should be putting the spotlight firmly on the people that are the abusers, whilst we ensure that we do the right support for those that are victims, that are surviving that with strength and dignity. So that was something that I felt really important to say in this point, that this is really great to see that. Also, what I'm really pleased to see is that there's a really, again, similar to the learning disability, there are certain communities that are very much still underserved in this space. And seeing that the deaf community has been highlighted was something that I was really pleased to see. In other parts of my world, I work in the cancer space where the deaf community are really poorly underserved in that area, and can see how there are ways in which we can work with that intersectionality of different impairments, different ways in people are affected differently, and how communication needs really do create barriers to how people are supported. So there's a lot to commend in this particular strategy. And similarly, I think it's going to be something that I hope that in another 20 years' time, I'm not here talking about this. Because that's been the thing for me, that, you know, I got involved in my 20s, I'm now 61, and I'm still hearing the same stories. Similarly, I was contacted at Health Watch by somebody not from this local authority, I'm pleased to say, where that issue of how we train our staff, so the trauma-informed training that's really necessary for those people that support people who are experiencing domestic abuse is really, really important. So many times I was talking with a colleague who used to be the chief executive of JSNA only last night about this issue of how so often when staff are not trained effectively in trauma, they can really do more damage when women who are going through some of the most traumatic times in their lives are then asked to do lots of different things, jump through hurdles to make sure that they can be seen to be deserving almost of the support they're being given, and forgetting that a lot of the behaviours that women, particularly women, because that is the majority, and I appreciate that this is a report that demonstrates this is across genders, but we still need to think about how we ensure that everybody that's involved with somebody who has experienced this has got the highest level of training and particularly understands trauma, and how trauma affects everything that you do, say, behave. And so that is really difficult when maybe there's children involved. And in the case I was brought into recently, there was a real sense of holding that over a woman. If you don't do these things that we want you to do to prove that you're no longer putting your children at risk, they'll take my kids away. And what transpired in that was a very big thing around how the people in those services just didn't fully understand the level of trauma that this young woman had been experiencing. Even the police were trying to advocate on her behalf to say she's having one of the worst experiences that they'd ever come across. So I think it's really important. It's a really important strategy. It's something that I'm seeing difference in, which I'm really pleased to see. And I really hope we don't need to do this again in 20 years' time.
Thank you very much, Sarah, and moving from what we were seen as victims to survivors. Councillor Wilmot, I remember you talking about this not long ago, about asking Angela and signals in local areas in Hucknall, and you took a passionate interest in it. Over to you, Councillor.
Yeah, I'm absolutely astounded that it says here the police recorded over $1.25 million domestic abuse related incidents. Absolutely incredible. And you have to know, I know of a few that never went to anywhere because they were frightened to death to go anywhere in case if the perpetrator found out, because it give the person a real good idea, which is absolutely astonishing. I mean, we need more investment in prevention and early intervention. There's no doubt about it, and to ensure that the perpetrators taken to task on this. I mean, I'm just looking at this, the experience of a domestic abuse survivor. It's astonishing that a person in a problem that got, the council, whoever they were, didn't put her down as a priority for a property. Because she was at work, she couldn't get a property. That's disgusting. You know, it absolutely is. And as I say, to say that the perpetrator had got two houses as well, you know, one he wasn't using and the other one that it was on his own. It's, again, an astonishing situation. The judicial system must be wrong if that's not sorted out. It really, and as I say, the person starting with absolutely nothing, and the other person's got everything. It's that should not happen. You know, obviously I support the 5 pillars that you put forward, which is prevention, protection, support for survivors, pursuing perpetrators, and I fully agree with the vision statement, which includes taking a zero tolerance stance against anyone that does it and got this that's causing this problem. And of course, we must, as I say, protect all the survivors on this situation. But to say 1.25 million, over 1.25 million domestic related incidents, and how many thousands that have never even come before us, that is absolutely mind-boggling, and it's a serious situation, and somehow has got to be addressed. I don't know how you do it, but it's got to be addressed, that situation. And I say, finally, the premise that survivors are given is security a priority. Many of the perpetrators find out where the person's living, which is a real problem. Are the properties, has it got enough security so that you can't just break in and make a right carry on and probably do something that we'd all regret. It's a very serious situation.
Thank you, Councillor Wilmot, for highlighting all the things we don't know anything about, such as under-reporting, etc. I'm going to go to Anne as the final speaker on this item. Thank you, Anne.
Yeah, thank you very much. Sharon, I find it really thorough, so I'm not Irene, am I? And you weren't.
Just answer to anything.
Yeah, look, I just want to say I find it really humbling listening to you, so thank you very much for sharing that. When you work in children's services, domestic abuse is one of our highest, most prevalent issues that affect children for the rest of their life. Actually, so it's a real, a really important subject to us. I just wanted, if you don't mind, just to really pick up on from our colleague from EMCA, because I genuinely think the cross-border working around domestic abuse is so important. We know both perpetrators, they don't stay in one place, but also actually we also know that some of our children and families need immediate protection, and that means sometimes out of the area. So working alongside EMCA to find really great ways of making that landscape much more inclusive in immediate times of strife can make an absolute enormous difference for children. And you know, we've got a great region here, the Children's Services and Adults work really closely regionally, but it's the wraparound and the real, you know, where, as we talked about, you know, where people sleep becomes really important. You're the real most vulnerable when you sleep, so being able to find situations across border would really help that. I was a bit inspired and I just wanted to use it, so I'll come to find you.
Thank you, and hopefully all of our work will be across boundaries as we move forward, as local government and organisation can't interfere with things that we do on that strategic level, like we did with the learning disabilities that James presented. Thank you, Amanda. I move the recommendations on page 150, endorse the final draft of the domestic abuse strategy and support the abuse training and specialist support services across Nottinghamshire and move the recommendations. Excellent. So we're going to finish very briefly, James, the work programme.
I'll run through this quickly. So just to remind that the next meeting of Health and Wellbeing Board is on Wednesday, the 17th of June. And to cover that, we do have the 2 items in the schedule, the Joint Health and Wellbeing Strategy Delivery Q4. So that's the Ambition 1 deep dive, which is to give every child the best chance of maximising their potential. So again, there will be a report and presentation to go with that. We also have the Better Care Fund Q4 national return. So that's the end of the year report with that. And there's also, that's come out of the meeting today, that Councillor Doddy has raised issues with the ongoing work on fluoridisation and the potentially joint strategic needs assessment on flooding. And we will build that into looking at how we build that into the work programme. We will also have a workshop, but do we have a topic yet?
So I think looking at the timescales, it's probably likely that we would need to be having some further conversations around the integrated neighbourhood health plan. So I would hope that by this time we would have a good draft to share with colleagues. Obviously, some caveats around timings in terms of when we get that national guidance out, but I would hope that we are well developed in our thinking by that phase. So I would imagine something on that as well.
And just to say that one thing that we didn't get bringing forward this year was joint pharmaceutical needs assessment. We're more and more looking forward to involve pharmacy in the wider provision of services, and it'll be no less so in integrated neighbourhood teams. And I think it's worth bringing back to just look at the challenges that pharmacies around the whole of the area are under, while being asked to deliver more and more services, and yet struggling more and more. So very important area which we will bring back in the fullness of time. And just to reiterate that this was a packed meeting because there was so much had to go into it. We're moving back to 6 meetings. Not all of them will have a workshop, but it will allow us to keep on top of the extraordinarily fast changing world that you've all seen today, that it's moving at a pace that you're either with it or you're left behind. And the Health and Wellbeing Boards are a centrepiece to the integrated neighbourhood teams of an extraordinarily prominent role in informing MCA with regards to health and well-being and how to make a success of the position that they've been put in. And most importantly, the tea and the biscuits have arrived. Thank you all, and I'll see some of you at the workshop hopefully. Thank you.